Hi, my name is Sydney Levine, and today I'm going to be answering Case Connection Cases 3 and 4. The scenario of Case Connection 3 is a 5-year-old boy is brought to the pediatrician's office for an annual visit. The mother reports he has been a sickly infant and often appears drowsy. She also has concerns over her son's persistent thirst and frequent urination. Blood samples are taken for insulin measurements at time 0 and 1 hour after a glucose loading test. The first question of this case states, what is this information likely to suggest about the underlying biochemical basis for the patient's symptoms? My answer to this is no insulin production by pancreatic beta cells. The clinical picture that is seen by this patient strongly suggests that the patient has type 1 diabetes. Type 1 diabetes is an autoimmune condition in which autoreactive antibodies and cytotoxic T cells attack beta cells in the pancreatic Langerhans islets, thus damaging or destroying those cells. The loss of function of beta cells therefore results in the significantly decreased production of pancreatic insulin and subsequent hyperglycemia. Patients with type 1 diabetes often appear drowsy, fatigued, have polyuria, which is frequent urination, and polydipsia, which is abnormally high thirst, being very thirsty. The majority of type 1 diabetes patients first exhibit symptoms and are diagnosed in the early years of childhood, hence the name, juvenile diabetes. The symptoms of the patient matches the symptoms of the early onset of type 1 diabetes. The results of the glucose tolerance test performed in the patient demonstrate abnormally low levels of insulin compared to the unaffected control patients. The lack of the insulin response shows or proves for the aforementioned symptomatic diagnosis of type 1 diabetes. The second question of this case states, what would you predict the patient's fasted blood glucose levels to be given his current condition? And my answer to this is that it should be significantly above the normal range, since there is a limited amount of insulin uptake. When looking at a healthy individual, pancreatic beta cells release insulin in response to the blood glucose levels rising. While glucose uptake from the body by the cells of the brain and the red blood cells is insulin dependent, the liver, muscles, and adipose tissue show insulin-dependent mechanisms of the glucose uptake from the blood. In the patient that is presented in this case, insulin production in response to the glucose loading test is severely impaired. This is showing the bulk of glucose that would normally be transported into the muscle tissue, liver, and adipose tissue would remain in the blood. This is why a fasting blood glucose level in this patient should be higher than fasting blood glucose level in a healthy individual. And since widely accepted clinical criteria for diagnosis of type 1 diabetes is fasting blood glucose level at or above 126 milligrams per deciliter in the venous plasma. Now the third question states, based on this diagnosis, what 2 regulatory enzymes are likely to be active in this individual's current condition? And my answer is this. Under normal metabolic circumstances, insulin inhibits the activity of glucose 6-phosphatase and phosphoenolpyruvate carboxykinase in the liver cells. In case of significantly reduced insulin to glucagon ratio, however, activities of both these enzymes in the liver will be increased. The scenario of case connection 4 states, a previously healthy 2-month-old female presents with jittery spells several hours after breastfeeding. Her mother reports she has not given the baby anything to eat other than breast milk since birth. The baby has only recently been sleeping for more than 2 hours between feedings, and that's when the mother reports these symptoms started. Laboratory results are consistent with hypoglycemia, low blood glucose, but are otherwise unremarkable. Epinephrine is administered, and there is no increase in blood glucose, but there is an increase in blood lactate. Physical exam reveals a liver edge 4 centimeters below the right costal margin. Percussion of the right chest and abdomen confirms hepatomegaly, which is an enlarged liver. Blood glucose levels increase after breastfeeding, but she cannot maintain blood glucose levels within a normal range during fasting. And to this case, my answer is that the patient demonstrates classic clinical picture of one of the glycogen storage diseases. An enlarged liver is a typical sign of the several types of glycogen storage diseases, type 3, type 4, and type 6. Based on the clinical presentation, the most likely diagnosis in this case is type 3 glycogen storage disease. And this is characterized by the reduced function of the debranching enzyme, the critical step in the process of glycogenolysis. Patients with this condition can get glycogen in the liver in the absorptive state, such as after a meal, but they're not able to recover glucose from the glycogen in the process of glycogenolysis in the post-absorptive state, such as between the meals. Epinephrine administration that should stimulate glycogenolysis and release of glucose in the blood has no effect on the blood glucose levels in the patient and thus confirms the diagnosis. That leads to the fasting hypoglycemia, which may trigger production of ghrelin, the hunger hormone. Ghrelin acts on the hypothalamus, triggering the sensation of hunger, which explains the feeding pattern of this patient. Continuous glycogenesis in the liver, together with the reduced glycogenolysis levels, shows that this patient's enlarged liver is due to abnormal accumulation of glycogen. And for this question, I'm going to explain why the other choices are incorrect, beginning with hereditary fructose intolerance. Hereditary fructose intolerance is a genetic disorder caused by the deficiency of the enzyme aldolase B. Symptoms of this usually include sweating, kidney damage, confusion, and low blood glucose, which somewhat match the symptoms observed in this patient, not all. But most importantly, the patient has only received breast milk as food since birth, so the patient's exposure to the potential sources of the fructose isn't very likely. The next answer choice that was incorrect is galactosemia. And this is a hereditary disease which is caused by the deficiency in the function of galactose-1 phosphate uridyl transferase. And for this disease, symptoms include vomiting, refusal to eat, and jaundice. And these symptoms do not match the presentation of this patient, specifically since the blood work did not detect increased levels of galactose in the blood. The last incorrect choice was glucose 6-phosphate dehydrogenase deficiency. And this is critical for the glucose 6-phosphate dehydrogenase is critical for the proper function of red blood cells, and therefore its deficiency can lead to the development of a life-threatening hemolytic anemia and severe jaundice in newborns. And this does not match the presentation shown in the patient in this case. Thank you.